Hello. So today we'll be discussing about the ECGs in MI. This is a very important topic clinically. But before going to this lecture, I must tell that you have to see the previous ECG lectures because many of the basic concepts I have already told in the previous lectures, and I'll not be repeating them again and again. And you have to remember that this is a continuum. So if you don't start from the beginning, it will be difficult to understand some of the concepts. Okay. So before going into the ECGs in MI, there are some points about the ECG findings in acute coronary syndromes that I've already discussed. I'll just name some of them. Something like Q waves. We have discussed the Q waves suggest either a acute, subacute, or chronic MI. ST elevation, of course, we have discussed. Now we'll see the patterns of ST elevation in different kinds of MIs. We have also discussed the differential diagnosis for ST elevation. We have discussed poor progression of R wave. That is also a finding for anterior wall MI. That also we have discussed in the basic lectures. Okay. But from that, we have also discussed the ST depressions, which are seen in NSTEMI, and the horizontal ST depression I have already discussed. That is seen classically in posterior MI. We have also discussed the Wellens pattern, which is seen in acute LED occlusion. We have also discussed about the D winter T waves, that is also seen in acute LED occlusion. So many things we have already discussed, and I will just compile everything and we'll learn something new. We'll see how different kinds of ECG patterns can be seen in a particular type of MI. Now, before seeing the ECGs, when you call ST elevation as a significant ST elevation, to now classify it as a ST elevated myocardial infarction. Now, significant ST elevation is called as significant ST elevation whenever there is ST elevation of, or you can say the J point elevation of more than 1 mm, more than equal to 1 mm in contiguous leads. In contiguous leads. Okay. If you remember the first lecture, in that I have told more than 1 mm means it corresponds to 0.1 millivolt. That is one small box in the vertical axis. Okay. But this applies to everything except from the V1 to V3. This is not applicable to V1 to V3. For V1 to V3, the ST elevation or J point elevation, ST elevation should be either more than 2.5, more than equal to 2.5, or more than equal to 2, or more than equal to 1.5. More than equal to 2.5 mm, this is true for males less than 40 years of age, more than 2 mm for males, more than equal to 2.5 mm for males less than 40 years of age, more than equal to 2 mm males less than 40 years of age, and more than equal to 1.5 mm for females. Okay. Now this is called significant ST elevation. This is important, and these numbers are important. Now for ST depression, significant ST depression, it is more than equal to 1 mm. ST depression is significant. More than equal to 1 mm, ST depression is significant. Of course, it has to be in contiguous leads. Now, what do you mean by contiguous leads? This terminology I have also used when I discussed about the ST elevation. I have told that ST elevation in contiguous lead is a feature of coronary events or myocardial infarction, but ST elevation diffusely is a feature of pericarditis. Okay. Now, what do you mean by contiguous leads? Contiguous leads means the leads corresponding to one particular wall of the heart. Okay. So for anterior wall, it is the lead V3, V4, V5, V6. It is like anterolateral. For anterior, it is only V3, V4. For septal, it is lead V1 and V2. Similarly, for lateral wall, it is 1 AVL, V5, V6. For inferior wall, it is 2, 3 AVF. So these are the leads. We will be discussing more on them. So these are known as the contiguous leads. For inferior wall MI, it is the 2, 3 and AVF that we have to see. So those are known as contiguous leads. So if you are getting ST elevation in these leads, that means it is a case of inferior wall MI. I'll start with anterior myocardial infarction. So anterior myocardial infarction, they are represented in the precordial leads from V1 to V6. Among them, The first two are V1 and V2 are known as the septal leads. Anterior leads typically V3, V4, lateral leads V5 and V6. Okay. Anyway, lateral leads also include one and AVL, but here I am writing only the precordial leads. Okay. Similarly, the different infarct patterns, how they are named. If only V1 and V2 are involved, you can tell as septal MI. For anterior, it is usually taken as V2 to V5. If there is ST elevation and V2 to V5, you just take it as anterior MI. You just name as anterior MI. Anteroseptal MI, you include both anterior and the septal. So V1 to V4 or V5, you can tell. Anterolateral means it is from like you can tell V2 to V6 or V3 to V6. Anything can be told. See, similarly, extensive anterior or anterolateral means everything V1 to V6. This is I'm talking only about the precordial leads. Okay, so remember, finding only septal MI or finding only anterior MI are very rare. So usually you get a combination anteroseptal, anterolateral, or extensive anterior, something like that. So combinations are important. This is just for the beginnings purpose. You can remember that septal leads are V1, V2, pure anterior leads are V3, V4, and lateral leads are V5, V6. Now, if you see here, you try to find out where is the ST elevation. As you can see, now one more point I have to tell that it is not only the ST elevation. Before ST elevation, I have already told you in the T wave section regarding the hyperacute T waves. In the T wave lecture, I think the second or third lecture, I have told you about the hyperacute T waves. Now these findings usually precede the ST elevation in most of the rates. Okay, so this is also a finding of early myocardial infarction. Usually they precede the ST elevation. So that is also one point you have to remember. Now, how to differentiate hyperacute T waves and tall T waves of hyperkalemia? So don't remember this. You have to go back to that lecture and see how to differentiate tall T of hyperkalemia and hyperacute T wave of MIs. Now, if you can see here actually these are hyperacute T waves. V2, V3, V4, somewhat V5. So it is basically a anterior MI. But apart from that, what else you can appreciate here? What else? So you can also appreciate that there is Q waves. You can also see the Q waves in V2, V3. In V1 also some extent there is a Q wave. So Q waves are also feature of coronary event. Okay. In V3 it is not very evident because there is a small positive wave, but V2 it is very much evident. Okay. So as you can see here, hyperacute ST elevation in V2 to V4 and Q waves in V1 and V2. Q waves in V1 and V2. So it is anteroseptal MI or anterior MI, anteroseptal MI you can tell. One more point I forgot to tell, there has to be reciprocal ST depression. This is also one more point. That differentiates from the acute pericarditis. This also I have previously discussed that you will always find the reciprocal ST depression in the opposite leads. That means if in opposite leads, that means if there is anterior MI and you are finding ST elevation in the anterior leads V1 to V4 or maybe V1 to V6, in those cases you will find ST depression in the inferior leads. That means 2, 3 and above. So you have to always look for the inferior leads. If there is anterior ST elevation MI, you have to look at the inferior leads and you will find the reciprocal changes. Reciprocal changes are exactly opposite of ST elevation. That means you will get a ST depression of almost similar pattern of exactly opposite ST elevation. Okay, so in case of anterior myocardial infarction, you will get in inferior leads ST depression. Okay, so as you can appreciate here, in lead 3 you can find somewhat ST depression. Lead 2 it is not very evident. Lead AVF again there is ST depression. This is ST depression. I hope you can appreciate. Okay, these are hyperacute T waves, and this is Q wave. Okay, this is also Q wave. Next ECG. Here you can see the clear-cut ST elevation. ST elevation is there in lead V2, V3, V4, V5, V6 also. And also, whenever I find ST elevation in V5 and V6, I told V5 and V6 are lateral leads. Okay, so whenever you find some kind of ST elevation V5, V6, that means there is lateral wall involvement. So you have to always look for lead 1 and AVL also. Okay, 1 and AVL also, which corresponds to the high lateral portion of the heart. So 1 and AVL corresponds to high lateral portion. So ST elevation in 1 and AVL uh, tells us about the high lateral MI, and V5, V6 just lateral MI. Okay, and whenever there is a V5, V6 involvement, you have to look for the 1 and AVL to look for the entire lateral wall involvement. So if you see lead 1 here, there is ST elevation, and if you see AVL also, there is ST elevation. Okay, so you can tell this ECG as, and you can also look for the QFs, which I forgot to tell. QFs are present in V1. The only negative wave in the QRS complex means it is QF, or you can tell as QS complex. In V2 also you can appreciate the QF. In V3, QFs are not there because there is initial small positive wave. V4 also no QF, V5 no QF, V6 no QF, lead 1 no QF, lead AVL no QF. So QF in V1 and V2. So this you can tell as extensive anterior wall because you can see it is involving entire V1 to V6, and along with that lead 1 and AVL. You may be asking that there is no ST elevation in V1. Even if there is no ST elevation in V1, there is QF in V1. That means V1 is also involved. Okay, so this is extensive anterior wall MI. So I hope this is clear now. So in case of MI, whenever you are trying to read the ECG of MI, you have to always look for the contiguous leads. So you can start with the precordial leads V1 to V6, and you know the patterns, and then you can look for the 1 AVL to characterize the high lateral wall MI, and finally you can just look for the 2-3 AVF, which corresponds to the inferior wall. Okay, so if there is ST elevation in these contiguous leads, accordingly you can tell the diagnosis. And almost all the cases you will get the reciprocal ST depression, and you can appreciate here in the lead 2 also there is ST depression, lead 3 also there is ST depression, AVF also there is ST depression. Okay, so these are reciprocal ST depressions. So coming to this ECG, you can see here ST elevations are not very prominent, but there are some residual ST. These are residual ST elevations, and you can see the prominent QFs V1, V2, V3, V4, V5, V6, almost all the rates. Okay, so these are this is suggestive of old MI because only the QF prominent QFs are there. So this is old MI, and there are some residual ST elevation. So most likely the diagnosis will be probably ventricular aneurysm. That is a cause for persistent ST elevation after an acute event of myocardial infarction. Okay, so this is ventricular aneurysm pattern. Next, this is a clear-cut acute myocardial infarction. Which leads are involved? V1, V2, V3, V4, V5, V6. Lead 1, lead AVL. So everything is involved extensive anterior wall or anterior lateral wall MI. You can see the reciprocal ST depression in V1, sorry, V2, V3 and AVF. Sorry, lead 2, lead 3 and AVF, not V2, V3. Lead 2, lead 3 and AVF. And the degree of ST elevation also corresponds to the amount of injury. So definitely if this kind of ST elevation is there, that means the patient will be like the cardiac function of the patient is very low. So this kind of ECG is usually found in those MI patients who present with shock. Okay, so very critical condition. And sometimes this is known as the tombstone pattern. Okay. Now what is this ECG? Here you can appreciate there is ST elevation in V1, V2, V3, V4, V5, V6 not much. And what else? If you see lead 1, ST elevation is not there. AVL, there is no ST elevation. You see lead 2, 3 and AVF. What is there? There is no ST, reciprocal ST depression. There is also ST elevation in lead 3. Lead 2 is not very prominent. Lead 3 and lead AVF definitely. Okay. So this is a case where there is anterior wall involvement and also there is inferior wall involvement. So this is anterior wall plus inferior wall MI. So till now we have discussed only about the anterior wall MIs. And remember one point I forgot to tell. Anterior wall MIs are caused by which artery involvement? It is due to the LAD involvement. Left anterior descending because that is supplying the front part, the anterior part. So this is due to this artery involvement, left anterior descending artery. Okay. And this artery is usually doesn't supply the inferior wall. But whenever we are finding a case where we are getting ST elevation in anterior leads and also along with that you are getting ST elevation in some of the inferior leads, that means it's anterior inferior wall MI. So how will you explain this? It is explained by LAD. Of course, there can be involvement of the two arteries, LAD and RC or LAD and L6, but it's a more likely situation if one artery is involved. If someone asks you, how will you explain with obstruction of one artery this anterior and inferior MI pattern? So this is known as LAD type 3 or the wrap around pattern. Wrap around pattern. What is this? Sometimes what happens is LAD after supplying the anterior wall, lateral wall, it will go back and supply the inferior wall. Okay, it will also supply the inferior wall. In those cases, you will get this kind of pattern, anterior inferior wall MI. So this is LAD wrap around. This wrap around term is very important. LAD wrap around pattern. Okay. Now, other important ECG patterns you should be aware of. Among these, I have already discussed about the Wellen syndrome and D winter T waves. These are seen in acute LAD occlusion. I'll not be discussing in detail again. You have to see the previous lectures. Wellen syndrome, there is two types, type A and type B. This is two types, type A and type B. In type A, you will get a biphasic T wave, and type B, you will get a symmetrical. Like this, you will get in type A, you will get a biphasic T wave. In type B, you will get symmetrical inverted T waves. D winter T wave is nothing but upsloping T wave. Upsloping T wave for the Kivaris, upsloping T wave. Anterior inferior MI due to occlusion of wrap around LAD, this I have already discussed. There is one more pattern which is seen in left main coronary artery stenosis or sometimes in triple vessel disease. Pattern is diffuse ST depression plus ST elevation in AVR. Very important finding. If you are getting ST depression everywhere in the ECG, you usually will tend to think that this is a NSTEMI. This is a NSTEMI, non-ST elevated MI. But remember, whenever you are getting a diffuse ST segment depression, always look at AVR. Always look at AVR. So if you are not familiar with the ECG, remember AVR comes here. AVR comes here, and you have to always look at AVR to look for the ST elevation in AVR. If there is AVR ST elevation, that means it's a more critical situation. Okay, you may have a left main coronary stenosis or you may have a triple vessel disease. It's a very important finding. One more thing I want to tell you here is these findings that I am discussing or these kind of ECG changes, these things are not uncommon. Okay, these things are not uncommon. I have seen all these patterns during my residency. So the best place to see the ECGs and learn ECG is your emergency. In your hospital, if you go to the emergency ward, ECG is being done for all the patients and where you will get all these findings. Okay, these things are not uncommon. So only thing is you have to know all these things to find out in the ECGs in the real life scenario. Okay, so everything this WPW pattern, all the bundle branch blocks, all the AV nodal blocks, everything is like all of them are they're not uncommon. If you go to the wards, if you go to the emergency department, you'll be seeing all those ECGs. The prediction of site of LAD occlusion. Here only two things you have to remember. One thing is there are certain pointers in this anterior MIs where you can tell that the location of the occlusion is higher up or before the diagonal branch or before the septal branch. Like something like that, you can predict the site of LAD occlusion. From this image, you can see that this is the S1, that is septal branch 1, and this is of course the D1, it is already written. If there is occlusion or occlusion above S1, remember this part. If this part is affected, then you will find the ECG changes like that of septal MI, So you will get ST elevation in the V1, ST elevation in AVR also, ST elevation in V1 and AVR. Other than that, bundle branch is also present like near the septum, so you may get bundle branch blocks. You may also get bundle branch blocks. So this findings you have to remember. If you're finding significant ST elevation in V1 and AVR, along with that, maybe sometimes you may get bundle branch blocks. So you can tell that this is the occlusion is higher up above the S1, above the first septal branch. Above D1, you can see this is the high lateral section. This is high lateral section, and you will get ST elevation in 1 and AVL. I have already told you that high lateral is 1 AVL, just lateral is V5, V6. So you will get ST elevation in 1 and AVL. That is above the D1. occlusion above the D1. So these are the only points you have to remember from this. Okay, so if you see this is, you can see definitely you can see there is ST elevation in V1, V2, V3, of course, suggesting a anterior wall MI pattern, but along with that, you are finding a ST elevation in AVR. Okay, so that means any patient with anterior wall MI involving the V1 or septal MI involving V1, V2, you have to always look for the AVR to see for ST elevation. If there is concomitant ST elevation in AVR, that has to be like occlusion above S1, occlusion above S1. What else you can see here? You can see definitely the QRS complex here is wide. If you remember, wide QRS complex means more than 3 small box or more than 120 millisecond. Definitely here it is more than, I think, around 6 or 7 small boxes. So definitely wide QRS, and what you can see is the M pattern, which is more prominent in V2, M pattern. Okay, and there is, you can see there is a delayed or slot S wave in V5, V6. So definitely this is a case of what? If you're in V1 and V2, you are getting a M pattern, that means it is a RBBB pattern. Okay, so this is RBBB, right bundle branch block. If you don't understand why this is called RBBB, you have to see my previous lecture on bundle branch blocks. Okay, so this is RBBB pattern, but I have already told you that whenever you are getting a right bundle branch block, you should not stop there. You have to look for the axis. Okay, if you see here, lead 1 is positive, AVF is negative. So 1 positive, AVF is negative. So this is left axis deviation. Left axis deviation. So if you are getting RBBB with left axis deviation, that means this is a bifascicular block where we are getting RBBB. Along with that, we are getting left anterior fascicular block. This is a case of bifascicular block. And I have already told you that whenever you are getting bifascicular block, you have to look for the PR interval. You have to look for the PR interval to find out whether there is a trifascicular block. Whether there is a trifascicular block. So if you see here, the PR interval. Okay, this is the PR interval, which is around 4 small boxes, and the normal PR interval is 3 to 5 small box, so it is normal. So there is no third block, so there is no trifascicular block. This is a bifascicular block, and I have told this is very proximal LED occlusion before the S1, before the like septal branch, and you are getting the bifascicular blocks. Okay. Now after this anterior wall MI, now we'll go to the lateral wall MI. I have already told you some points that usually if we are telling only about the lateral wall, it is usually corresponds to the V5, V6, and if it is high lateral, then it is AVL and V1. Sorry, AVL and lead 1 and AVL. Okay, and if it is extensive lateral wall or entire lateral wall, then all the leads will be showing ST elevation. Okay, so if you see this ECG, here there is ST elevation in lead 1, lead AVL. Then which all other leads we are showing? Lead V1 is not showing, V2 is not showing, V3 is not showing, V4 is not showing, V5 there is slight ST elevation, V6 there is no significant ST elevation. Okay, and other if you see the the lateral wall, the inferior walls, 2, 3 AVF, everywhere there is ST depression. Even V1, V2, V3 is showing ST depressions. So this is a case of, you can tell, high lateral MI where there is significant lead 1 and AVL are showing significant ST elevation. There is something known as South African flag sign. Okay, South African flag sign. This is a pattern of ST elevation caused by acute occlusion of first diagonal branch of the left LED. Okay, so LED D1 if occluded, you will get a high lateral wall pattern, and ST depression lead 3. Sometimes you will get ST elevation in lead V2 also. So that is known as South African flag sign. I'll show you how it is, why we are calling it a South African flag. So if you see here, there is ST elevation in lead 1, ST elevation in lead AVL, sometimes ST elevation in V2, and there is ST depression in lead 3, ST depression. So this is elevation, this is depression. So sometimes this is called as South African flag sign. You can see this image. It is not very important, but you can just remember the name South African flag sign, which is seen in lateral MI due to first diagonal branch occlusion. Okay. Now coming to the next ECG, you can see here there is ST elevation. Lead 1 is not involved, lead AVL is not involved. Lead V5 you can see there is ST elevation, V6 there is ST elevation. In lead 2 also there is ST elevation, lead 3 also there is ST elevation, lead FF also there is ST elevation. Okay, so this is inferior lateral wall MI, inferior lateral wall MI, and this can be seen by that LED wrap around pattern. Now coming to the inferior MI, very important. Inferior MI is very important here. I already told that inferior leads are involved, 2, 3 and AVF. 2, 3 and AVF. You may get ST elevation, you may get hyperacute T waves, you may get Q waves. Okay, but along with that, many times in inferior MI, we may get some associated features which confer a worse prognosis, which confers a worse prognosis. The first associated feature is RVMI. Whenever there is inferior LMI, you have to always look for the right ventricular MI also. Second point is posterior MI. So whenever there is inferior MI, you have to also look for posterior MI. Third point is this right ventricle, because vagus nerve is very close to this right side of the heart. So whenever there is right ventricle MI, whenever there is inferior part of the vagus is inferior part of the heart, right side and inferior part of the heart. So whenever there is inferior MI or right sided MI, you have to always look for like vagus nerve is likely to be involved, and also the AV nodes are like AV node is likely to be involved because it is present on the right side. So you may get AV nodal blocks, AV blocks, or you may get a like increased vagal tone bradycardia. Okay, so all this confers a worse prognosis. So these are all the associated features of inferior wall MI. Will see them one by one. Don't neglect AVL. Why this point is important? Now remember, this is AVL is the only lead that is truly the opposite of inferior wall. Truly opposite of inferior wall. That means if you want to look for reciprocal ST depressions, if you want to look for reciprocal ST depressions in one lead, in case of inferior MI, in case of inferior MI, if you want to see reciprocal ST depression in only one lead, that has to be AVL, because this is the truly opposite of inferior wall. Okay, many times what they have seen is patients may present with isolated ST depression in AVL, isolated ST depression in AVL, and they will be found as occlusion of inferior wall arteries. I'll be telling what are the inferior wall arteries. There are two arteries. One is RCA, right coronary. Another one is LCX. Both can be involved in case of inferior wall MI. RCA is more commonly involved than LCX. So what they found is in many of the cases of inferior wall MI, there is no ST elevation in 2-3 AVF, but you may get isolated ST depression in AVF. So isolated ST depression can also be satisfied. Sometimes you have to be very keen to look for this finding to tell it as a inferior MI. Okay, maybe you have to do serial ECGs, or you may have to do other invasive modalities to find out the block. So AVL is important. Then next point is which artery is the culprit. I have told like most likely the two arteries that are involved are RCA and L6. So RCA, L6. But in the anterior MI, I have already told that LED sometimes can also cause inferior MI. That is known as the wrap around pattern. This I have already told you, but this is very rare. It's seen in only 2% of cases. RCA is involved in 80% of cases. L6 is involved in 18% of cases. Okay, so mostly it is due to these two. And 2% cases, it's due to LED is very simple to identify, because in case of LED, you will have anterior MI along with the inferior MI. But how to differentiate whether it is whether the inferior MI is due to RCA involvement or due to LCX involvement? So what are the pointers that RCA is the culprit artery? So if ST elevation in lead 3 is more than lead 2, if ST elevation in lead 3 is more than lead 2, it is more likely in favor of RCA, right coronary artery. Along with that, if there is associated RVMI, that is also more likely in favor of RCA. Okay, so what are the features suggestive of RVMI that I will be telling later? Subsequently, I will be telling what are the features in a normal ECG that there is right ventricular MI. I will be telling later. Okay, so remember these 2 points. If lead 3 ST elevation is more than lead 2, this is due to RCA. If lead 2 and lead 3 are almost equal, also most likely it is due to RCA. If lead 2 ST elevation is more than lead 3, which is very rare because LCX is involved only in 18% of cases, in that case you may be thinking of LCX. And what other point you have to remember in case of LCX? As I have told, in case of RCA, it is RBMI that may be associated. LCX you may find associated lateral wall MI, lateral wall MI. That is 1 AVL, V5 and V6. I will see the ECGs. So we are focusing on inferior MI, so we have to look for the lead 2, 3 and AVF. So you can see in lead 2, ST elevation is not prominent. You can see a hyperacute T wave maybe not very prominent, but lead 3 definitely there is ST elevation. Lead AVF also there is slight ST elevation. And what I have told you have to see the reciprocal changes in AVL. So AVL is very important for the reciprocal changes. Okay, and definitely you can see that lead 3 ST elevation is more than lead 2. So here the culprit artery is again RCA. Okay, and also you can appreciate that there is Q wave in lead 3. Okay. Now we'll see this ECG. It is showing again 2, 3, AVF. You can see there is 2, 3 and AVF. What else? If you see lead AVL, there is ST depression. Okay, there is ST depression. And again you can see that lead 3 is more than lead 2. Lead 3 is more than lead 2. So this is also a case of RCA involvement. RCA involvement. Now you told inferior MI they may be associated with bradycardias, AV blocks or bradycardia. Now what is the mechanism for bradycardia? Now first question is what percentage of inferior MI patients will present with brady? This is around 20% of cases. So 1/5 of inferior MI patients will present with brady. And various types of AV blocks. Mechanism is two mechanisms. One is AV node involvement or AV node ischemia. Another one is known as the Bezold-Daris reflex. Bezold-Daris reflex. And this is due to increased vagal tone. This is due to increased vagal tone. Okay. So, but the last point that is written here is very important. Bradyarrhythmias and AV blocks in the context of inferior MI, they are usually transient and respond well to atropine and do not require permanent pacing. Okay. So temporarily, if there is hemodynamic instability, you can do pacing, but most of these patients will not require pacing for a longer time. So this is very simple, straightforward. This is if you see the rate here before going to ST elevation and all. If you just look at the rate here, definitely there is bradycardia. And if you look at the rate, 1, 2, 3, 4, 5, 6, 7, almost 8. So the rate is around 300 divided by 8. So it will be around 37 or 38, something like that. So this is definitely a ventricular rhythm. So there is AV dissociation, ventricular rhythm, AV dissociation. And you have to remember one point, whenever the heart rate is around 35 to 40, whenever there is a heart rate of around 35 to 40, most of the time the diagnosis will be complete heart block or third degree AV block, complete heart block or third degree AV block. Now I have not discussed about AV block, so this might be a little bit difficult for you to understand, but I'll be discussing it later anyway. But for now, if you just remember that in case of complete heart block, when there is complete AV dissociation, the heart rate will be around 35 to 40. So anytime if you are getting a ECG showing a heart rate of around 35 to 40, most of the times there is third degree heart block. So definitely here there is third degree heart block, and definitely you can see 2, 3 and AVF there is significant ST elevation. 2, 3 and AVF there is significant ST elevation. In AVL you can see the ST depression. So this is inferior MI with complete heart block. Now coming to the right ventricular MI, I have told these are usually associated with inferior MI. Okay, these are usually associated with inferior MI. Now, how will you find out in a ECG of normal 12 lead ECG? How will you find out right ventricular MI? That means in a given case of inferior MI, how will you suspect that there might be associated right ventricular MI? So what are the pointers? The first pointer is you have to look at the V1. If there is significant ST elevation in V1, that means you have to suspect there might be a right ventricular MI. Why? Because if you remember the positioning of the ECG leads that I have discussed in my first lecture, the V1 is the only lead which is which we kept on the right side of the sternum. So this is the only lead which represents the right side of the heart in a normal lead system. So that's why V1 is very important. If you are getting ST elevation in V1 along with the inferior MI pattern, then you have to think of a right ventricular MI. But what else you have to remember? If there is ST elevation in V1, ST depression in V2, ST depression in V2, this is highly specific for right ventricular MI, for right ventricular MI. Okay, so these are the pointers. But it has to be confirmed by right-sided leads. How will you place right-sided leads? This I have already discussed in my first lecture. So you have to go for V3 to V3R to V6R. You have to see these are the right-sided leads, and you will get ST elevation in these leads. Among them, the most important lead is V4R. If you want to look for only one lead in the right-sided leads, you have to look at the V4R. Now, if you see here, this is you can see there is ST elevation in lead. One more point I forgot to tell. RVMI is caused by involvement of the RCA, right coronary artery. So that means the lead ST elevation lead 3 has to be more than lead 2. This point also you have to remember. So in case of inferior MI, if you are getting this finding, lead 3 is more than lead 2, ST elevation in V1 or ST elevation V1 with ST depression in V2, these are the findings suggestive of RVMI. So the first finding we are getting is lead 3, definitely it is more than lead 2, definitely more than lead 2. AVF is also involved. We can appreciate there is ST depression in AVL. We can also see there is ST elevation in V1. ST elevation in V1. Now in this case, we are suspecting the right ventricular MI because all the features are there. 3 more than 2, ST elevation in V1. Of course, there is no ST depression in V2, but anyway, that is not very, that is not always required. Now what to do? You have to do the right-sided leads. These are the right-sided leads, and you can see in the V4R. This is V4R, and here there is ST elevation in V4. ST elevation V4R. So this is confirming the diagnosis of RVMI. Now, what is the clinical significance of RVMI? If there is RV infection, these patients will respond to preloading. Will respond to preloading. So usually in case of patients with myocardial infarction, because the heart is not functioning well, we don't give fluids because it will lead to pulmonary edema. But this is the only condition inferior MI and with some right ventricular involvement. This is the condition which will respond to fluid, IV fluids. So that is very important. So it is very important to identify the RV infection. If it is there, they will respond to fluid. So if the patient is going into shock, you can try with a bolus of fluid challenge. Now coming to the last part, that is the posterior myocardial infarction. Now how to spot posterior infection? This is again I have told these posterior infections are usually associated with inferior MI. So in a case of in a ECG of inferior MI, when you suspect that there is a posterior wall involvement, this point also I have discussed previous lectures. ST depression, horizontal ST depressions in lead V1, V2. If you are getting horizontal ST depression in lead V1, V2, then you have to suspect a posterior wall MI. Then you have to suspect a posterior wall MI. And along with that, what you have to remember, you have to always take the posterior leads. So posterior MI is suggested by which of the following changes in V1 to V3. These changes in V1 to V3, you will get horizontal ST depressions. And then you have to take the posterior leads. I have already told you how to take posterior leads. So this is what I am talking about. These are the horizontal ST depressions. Horizontal ST depressions. Lead 2 is very second. One more point is this R wave, significant R wave in V2. So R by S more than 1, or you can tell R more than S in V2. This is also a finding for posterior MI. We'll just mention it here. R more than S in V2. This is also a finding for posterior MI. Of course, you have to confirm with the posterior leads. Okay, so here you can see that there is inferior MI, 2, 3, 3 is not much involved, AVF. Along with that, you can see horizontal ST depressions in V2, V3, and V1 also some extent. I think there is a ECG for the posterior walls. Yes. So these are the posterior wall ECGs, and V7, V8, V9. You can appreciate there is ST elevation. So this is a case of posterior wall MI. Now, the next point is about the Scarbosa criteria. About the Scarbosa criteria. Now, what is Scarbosa criteria? This criteria is designed to identify MI, to define MI in cases of left bundle branch block. If you see the bundle branch block ECG section, I have told you in case of left bundle branch block, you will get ST elevations. You will get ST elevations, and in that situation, to find out whether actually there is MI or just LBBB, it is very difficult. So that's why they have defined a criteria that is known as Scarbosa criteria. In most of the situations, at least for exam set, nobody will ask you to apply the Scarbosa criteria and give the diagnosis. But the name is important. LBBB MI, to identify MI or ST elevation in LBBB, the name of the criteria is Scarbosa criteria. If you want to understand what is this criteria, in the original criteria, there are some scores given to 3 important components. The first thing is concordant ST elevation of more than 1 mm in leads with positive QRS complex, that is given as score 5. Concordant ST depression more than 1 mm in lead V1 to V3, given score 3. Excessively discordant ST elevation of more than 5 mm in lead with negative QRS complex. Now this may sound complex, but I'll just show in the ECGs, then we'll be able to understand. So if you remember, in case of LBBB, you will get in V1 what you will get? You will get a strong negative wave or W pattern, and V6 you will get a M pattern. That means in V1 you will get the QRS complex will be negative. V1, V2, usually the QRS complex will be negative. V5, V6, the QRS complex will be positive. Okay. Then you have to understand what do you mean by concordant, what do you mean by discordant. If the ST segment is the changes in ST segment is in accordance with the QRS complex, that means there is ST elevation is happening in the same direction as the QRS complex, then it is known as concordance. That is what is happening here. I think actually none of the leads are showing a concordant ST elevation here. All of them are showing discordant. That means, what do you mean by discordant ST elevation? That means QRS complex is in one direction, ST elevation is in opposite direction. I hope it is clear now. At least in V2, you can appreciate that the QRS is predominantly negative. It's purely negative, and ST elevation, ST changes is happening towards the positive side. So this is known as discordant. If both are happening on the same direction, that is known as concordant. If both are happening in the same direction, that is known as concordant. I think in the AVL they want to show AVL. You can see there is a positive RUF QRS complex along with the ST elevation. So this is concordant, and this is discordant. Now for MI, concordance is important. MI concordance is more specific. Concordance is more specific. That's why this concordance has given more points. So if you see the criteria here, if there is a concordant ST elevation of more than 1 mm, score is 5. So whichever leads will have a positive QRS complex, only those leads can show a concordant ST elevation. Okay, so if those leads are showing ST elevation, that is known as concordant ST elevation. So only leads with positive QRS complex can show concordance ST elevation. And if it is there, that you have to give score 5. Okay, you have to give score 5. Those leads which are showing a negative QRS complex, they have to show ST depression to call it as concordant. Okay, so usually in LBBB, V1 to V3 will show negative QRS complex, and in those leads, if there is ST elevation, that means that is known as discordant. And discordant is not a feature of MI. It's discordant, it's not very specific for MI. So here we are looking for concordance. So in V1 to V3, if there is ST depression, that is significant. If there is ST elevation, it is not significant. We have to take a higher cutoff. If there is ST depression, that is concordance, so that is more in line with myocardial infarction. So they have given 3 points for that. I hope it is clear now. So even if you don't understand this, you can just forget it because it's not very important. The name of the criteria is important, but the details are not important. Until in a real life scenario where you have to see LBBP and you have to differentiate it from myocardial infarction. And uh, uh, and it's really difficult in even in a real life scenario to apply this criteria. It is really difficult. Okay, so again coming to this concordant ST elevation of more than 1 mm, score 5. Concordance ST depression in V1 to V3, score 3. And if there is a discordant ST elevation, which usually happens in V1 to V3, as I am showing here, this is discordant. So if it is discordant, that means it is less likely MI. So we are giving a higher cutoff. So cutoff is more than 5 mm, more than 5 mm. So if it is that, then even if it is there, score is less, score is 2. And we have to see all of them, and you have to add up the scores. If score is more than equal to 3, it is 90% specific for myocardial infarction. 90% specific for myocardial infarction. Now this is the original Scarbosa criteria. However, Smith has modified the Scarbosa criteria. Details, I will not go into the details. So this is what I am trying to tell. So this is actually discordant because QRS complex is in one direction and ST depression, ST changes is in other direction. Here also you can see QRS complex is negative, ST is in positive side. So this is discordant. In case of LBBP, in V1, V2 and V3 you will get this kind of changes, and in V5 and V6 you will get this kind of changes usually. Carbosa's criteria, if it is concordant like this, this is 1 mm. 1 mm is sufficient and it will give you a score of 5 point. 5 point you will get. If it is like this, if you are getting this kind of pattern, that means there is ST depression, but it is in accordance with the QRS complex. This is given 3 point. This is concordant. This is also concordant change. This is also concordant change. But in case of discordant change, if you are finding there is a significant ST elevation of more than equal to 5 mm, this is given as 2 score. You add up everything. If it is more than 3, then it is more likely MI. Okay, so I spent a little bit more time this criteria to trying to explain you this. So I hope it is clear now. Then this is a very rare pattern. This is inferior occlusion MI, in a patient with multivessel disease. If there is inferior occlusion MI, then you may sometimes get a Slanger pattern. It's a very rare pattern, but I have seen one case during my residency. What happens here? There is isolated ST elevation in lead 3 and ST depressions in V4 to V6. Sorry. Just 1 minute. Yes. So V4 to V6, anywhere you may get a ST depression and isolated ST elevation in lead 3. If you see here, there is isolated ST elevation in lead 3 and you are getting ST depressions in V4, V5 and no, V3 there is no ST depression significant in V4 and V5. So this is known as a Slanger pattern. So ST elevation in lead 3, ST depression any leads in V4 to V6. ST in lead V1 is higher than ST in V2. This is not very important, but you can remember. So these are the 3 points for a Slanger pattern described in 2020. This is due to inferior wall occlusion MI in patient with multivessel disease. So that's all about the ECGs and MIs, and you will be finding the PPT to this lecture in the description. So definitely go to that. If you are new to these things, then definitely you have to look at the previous lecture. Then you see this lecture and try to see this multiple times so that you will be able to understand. I hope this is clear. So if any doubts or if you want give any suggestion, you can definitely comment. You can put in the comment section. Thank you so much for listening.